Our next presenter is Richard Gitomer. Richard's the director of the Brigham Health Primary Care Center of Excellence. He'll be speaking on primary care, flattening the curve while the system manages the peak. Thank you, Richard.
Thank you, Susan. I'm going to share with you how we attempted to meet the acute and chronic care needs of our patients during the COVID pandemic at Brigham Health Primary Care. Our operating premise was that primary care's role in the pandemic response was to help flatten the curve. Next slide, please. This slide outlines our tactics. In order to meet our patients' needs, minimize staff exposure, and preserve PPE, we consolidated into a few sites, as you see here. We performed in-person visits at the respiratory illness clinic and the non-respiratory clinics. We only provided virtual care at our operational sites, which was most of our sites. These sites managed acute and chronic conditions and provided virtual visits before any in-person visit at a respiratory or non-respiratory site. They also performed all the remaining non-visit activities of a primary care practice. We executed both virtual and in-person outreach strategies for vulnerable populations. We did phone and video outreach that was to medically and socially at-risk patients. And then we provided temporary in-person sites. They were erected in neighborhoods that were most impacted by COVID. And in these sites, we offered COVID testing, social determinant screening, provision of food resources, and safety kits. Next slide, please. It's too early to determine clinically meaningful outcome measures, but our hypothesis was that maintaining substantive interactions with our patients was a first step to delivering high quality. So we decided to use encounters as a process measure. In the vertical bar graph, we show overall patient touches, and this includes face-to-face, telemedicine, phone and electronic messages, and social work encounters. And so you see by the third week, 70 to 80% of our total encounters, we achieved 70 to 80% of our total encounters compared to baseline. And then by early April, our virtual volume had approached 70 to 80% of our baseline in-person volume. The outreach initiatives touched about 2,000 people per site. Now, unfortunately, not all of our outcomes were as favorable. And if you can go to the next slide, please. These graphs represent one proxy for the impact on clinical quality. The sudden deflection downward in each of the graphs coincides with when we mobilized for COVID. I mean, some of this was unavoidable, but I think in retrospect, we might have been more intentional about developing processes to collect key labs and utilizing home monitoring more effectively. Now, the rapid transformation made by our practices employed strategies and interventions that we'd previously been very slow to adopt, but were very interested in implementing. So we hope to use our COVID response as an inflection point, furthering our pursuit of sort of the ideal primary care. The tactics required to execute our response to COVID resulted in higher levels of team-based care, patient-centered care, equity, and value. The pandemic has been tragic on many levels. However, the urgency of the need provided the activation energy for us to acquire new skills and adopt key tactics that will help to accelerate our pursuit of ideal primary care. So thanks for your attention, and I'm happy to entertain questions with whatever time's left.
So we have one question, Richard, and that is about how is this going to impact primary care? Is this an inflection point for how primary care is going to function going forward?
I mean, I think, it is an interesting opportunity in that just the acute need and the acute crisis forced us to do things that we hadn't done before, or we hadn't done at any scale before. And that includes team-based care, where we created these respiratory clinics and non-respiratory clinics, and we had to share the care of a patient, where we adopted virtual care. We did more telephonic care than we had done previously, that we did proactive outreach to vulnerable patients, whether they be socially vulnerable or medically vulnerable. And then the in-neighborhood outreach, we'd struggled with some of our quality measures for the final 10 to 15%. And I think a lot of that's an equity issue. And so doing this type of outreach and showing us that we can do these things and that it isn't so disruptive, I think will be very powerful as we try to move forward. And we're putting a lot of effort in trying not to lose that momentum.
Great. And in the 20 seconds that remain, could you speak to telehealth at all and what you learned and how that might change?
I mean, I think that as a primary care doc, there's a lot that telehealth can offer, and I think that a substantive portion of our visits going forward can definitely be telehealth. And I'll be honest, before this pandemic, I believe that telehealth didn't offer anything more than a telephone call, and I was wrong. It's much richer. The patients appreciate it. There are things you can do without requiring the patient to come in. It's more time efficient. There's obviously some support strategies that we have to develop, but I think it's demonstrated us its power.
Great. Thanks so much, Richard.